It's a great honor and a wonderful opportunity of being able to share the outcomes of the project. The purpose of choosing particularly this project was to actually share not only the outcomes of that Physical Scholar grant, but also that how it has actually shaped our future plans and how it has directed us in actually connecting the pieces of puzzles which were missing. So if I say this project has worked as a base of our lots of future projects and guided us, as a ray of where to go. And it worked as a pavement for us in field of adolescent health. So this is also very close to my heart in that terms. So without wasting any further time, I'll move forward. And Stefan has already told you that I work at Hart University, and and university has always supported us in terms of academics and research work, and this is the reason that today I'm here and I'm able to present it. And of course, University of Alberta, which gave me an opportunity of thinking about and diverting my or shifting my idea of research towards data synthesis also, which was not it is my cup of tea. Despite of being epidemiologist and statistician, I never thought of synthesizing the data and its importance, and I never thought that my entire it's going to act as a building block in my research career in field of adolescent health. So this is my team. I was mentored by Dr. Salima Meher-Ali, who is Associate Professor at University of Alberta, Yasmin Parpio, who is part of Khan University School of Nursing and Midwifery. And I also had Dr. Zohra Lassi in my team, who is at University of Adelaide. So today's presentation will talk about methodology that we have used for data synthesis. It will also talk about the the results, conclusions from the study, and we'll discuss about the roadmap of our what brought or what came with this meta-analysis. Why we chose the sexual reproductive health among youth? Because SDG 3 and SDG 5 are highly, highly supportive and highly reinforced agendas towards the health equity, which says 3.7 SDG says that universal access of sexual and reproductive health care and family planning is mandatory for everybody. And similarly, 5.6 again reinforces that universal access to the reproductive health and right should be encouraged. Unfortunately, the data from the WHO indicates that 2.1 billion of the world's population is adolescents, and 80% of the entire 2.1 billion lives in low middle income countries like Pakistan, Bangladesh, India, Sri Lanka, and many other underdeveloped countries. However, when we see from other LMICs. So it says that 789, which is near 800 per lakh youth is suffering from adverse maternal morbidities, according to 2015. And it also says that every day still 3,000 young people die of sexual reproductive health morbidities, which can be prevented. And just because of inaccessibility of health services or other factors that we are going to discuss, these are the reported deaths, and the estimates for the underreported data can be even high. And it also says that 27% of adolescent girls are already married in LMICs as compared to 5% of the adolescent boys. So it means that every 2 or more than 2 girls out of 5 in LMICs get married in their adolescence age. which is we can say that getting married very early and then bearing the consequences and adverse outcomes of the health. Because I can say this, that they are bearing the adverse health outcomes, because recently we have just concluded a scoping review which is in press, and it has shown that it is very rare that a teenage pregnant woman does not undergo the complication as compared to the women who get married later. So this is another piece of puzzle that we have explored after completing this meta-analysis. Moreover, when we see the data from Asia alone, it says that 1/3 of the girls under 18 get married in Bangladesh, India, Pakistan, Afghanistan, and Nepal. And these statistics get even worse during the natural disasters, floods, and in any humanitarian settings, because of poor understanding of sexual reproductive health rights, poor legislation, poor political stability. They have to get their young girls, especially get married for their safety, or they have to sell them out because of the circumstances in the humanitarian settings. So the kind of disasters these underdeveloped countries and developing countries are facing, it gets the statistics even worsened with time. In South Asia, 50 to 60% of the adolescent pregnancies in South Asia are intended. And like I said, that another review of our revealed that girls don't even know about the, contraceptive methods. Another statistics states that 23 million youth has unmet needs, and that is the reason of high unintended pregnancies also in developing countries of Asia. In Pakistan alone, 28% of young men are aware of safety or HIV prevention. And today I was reading an article that was a great literature that Pakistan is turning out to be among top 5 countries with high or inflation in the rates of HIV, unfortunately. So yeah, we are standing at the alarming situation now, despite of the high risk of underreporting of the data. 30% of the youth between 10 to 24 years old in Pakistan is actually comprising the whole population of Pakistan. So we can safely say that 30% of the people of the Pakistan are between age 10 to 24, which is a huge number, because our pyramid also is like very much, inflated from the bottom, and which says that this population is really high. However, we lose this population somehow after middle age or in the later age because of the neglected adolescent health, because of the measures that are supposed to be taken within this age group are lacking at large. 63% of young people in Pakistan have difficulty in accessing the knowledge of SRH. So I'm not talking about the access of healthcare services or the family planning or things, but they still have the issues in accessing the awareness about sexual reproductive health rights, which is an alarming situation in Pakistan and similar countries. There is data from Mary Stoops which says that even still in Pakistan, most of the girls come to know about their, menstrual health through their mother-in-laws. Or there is a almost like 63% of the girls were never taught about the menstruation, and they did not, nobody has ever told them. They just experienced and explored themselves. And in Pakistan, the ideal age of the marriage for the boys is somewhere in, you can say, in adolescence. So yeah, girls and boys do get married between 12 to 18 in Pakistan and 20 to 24. So in countries like Pakistan, people get married during either the adolescent age or between 20 to 24, where they are still struggling, because this is the age where we want to see our youth in the universities, So these are the factors which also contribute to their poor economies, their poor standing in the society as an educated and independent person, or if they are independent and educated, they are loaded with other responsibilities, despite the fact that they are not prepared, because we belong to the region where we are not still open about SRHR communication or sexual reproductive health things. And it's mostly supported among the communities or the people who are already married. But we do not educate unmarried people about, or we do not prepare them for sexual reproductive health changes or dynamics of the life that align well with the needs. So our study planned to see the pool prevalence of sexual reproductive health services utilization among youth, and we also wanted to see what are the predictors of these, service utilization in LMICs. And we registered our meta-analysis, and we followed the PRISMA guideline. We used almost all the reliable and resourceful databases for this meta-analysis. And the studies that we included were quantitative study designs, particularly focusing LMICs, community settings, family-based surveys, clinical-based surveys. We included everything from 2010 to 2023, published in English. And we excluded the case report, gray materials, or the data that has been published twice or thrice. Our study, for our study, the main outcome was sexual reproductive health services utilization. Any of the things, if a person has used, whether it is sexual reproductive health information, education, counseling about contraceptives, pregnancy testing, sexual transmitted diseases, or safe abortion, any facility if a person has used was called as user, and we compare the data with non-users of sexual reproductive health services in LMICs. Almost out of 46 studies, 2 were of the moderate quality, and 44 studies were having the high quality upon the quality appraisal. So pooled prevalence was calculated using JBI Somari, which was facilitated by Dr. Zohra Lassi, and she also assisted us with the review manager software and the calculation of the, and synthesis of the data. So we reported the confidence interval and odds ratios, and we also reported the I-square statistics for homogeneity assessment. Our very first objective, to our surprise, was the pool prevalence, but we did not expect that in low middle income countries, the pool prevalence of the 46 studies can be somewhere around 35%. And which means that out of 10, not even 2 people in low middle income countries are using sexual reproductive health services, where on the other hand, we have the high burden of teenage pregnancies, we have high burden of adverse maternal and child health outcomes, we have poor support system for our LGBTQ plus community, and we also do not possess a good reporting system. And on the other hand, we have the inflation of HIV in progress, I would say, which is unstoppable. And every other day we have the huge number. And here we have the highly alarming indicator of not even 2 people out of 5 or not even 4 out of 10 are aware or are utilizing the sexual reproductive health services in low middle income countries. So when we wanted to see that what are the predictors of sexual reproductive health services utilization, we found that people who are more educated, who have the education from secondary to the above, education level, they were better utilizers of sexual reproductive health services as compared to the illiterate population. So education plays an important role, as we know. It is something that improves the health indicators at large. When we compared the age groups, so we found that the young people between 10 to 14 years are poor utilizers of the sexual reproductive health services, which can be due to the taboo attached, which can be due to lack of sexual reproductive health education in the school, which can be because of the conservative societies, be that Muslim countries or the Indian countries or whatever. But no middle income countries have this poor integration of the sexual reproductive health education in the curriculum. However, with increase in age, that is 15 to 19, we see a better utilization. And then, of course, between 20 to 24 is the best utilization of sexual reproductive health services, which can be because of actively participation of the sexual activities. It can be due to the marriages happening between 20 to 24 the most. So there are many factors that are contributing, but our young people are deprived of it at large. And gender, our study did not find much of the difference as gender, but it can be because we have most of the studies having only female participants. So that the data might have gotten diluted. However, some of the studies individually reported that male has the better access, and males are more free to utilize the SRHR or talk in the society as compared to female, especially in the conservative societies of LMICs. Living arrangement has also, significant impact on sexual reproductive health services utilization, because those who live with the family, they have comparatively poor sexual reproductive health services utilization as compared to those who live either alone or with a partner. And that is subjected to because of the strict parental monitoring, maybe because of the family rituals, maybe because of the topic is not being accepted by the family, and so is the action of the youth. So that is the reason that those who live alone or with their partners are better utilizer of sexual reproductive health services as compared to those who live with their families and friends. Families where there is a good or healthy discussion about sexual reproductive health services with their children are better utilizers of sexual reproductive health services. There is a high chance that they will utilize sexual reproductive health services as compared to the poor utilization among the youth, where there is no discussion about the sexual reproductive health services. Similarly, those who discuss the things with their peers or in their school clubs, they have exponentially, high utilization of sexual reproductive health services. That can be because of their peers using, that can be because of in the school clubs, the sexual reproductive health services is part of some of the schools. So yeah, it has a positive impact on utilization as compared to those who do not discuss with peers or their groups. Some other factors that contribute significantly to the sexual reproductive health services utilization is how much services are close to their home, the convenience of the hours for these users, parent and adolescent sexuality communication has the good impact on utilization. And if any individual has been through any sexual reproductive health problem or sexual activity in the past, that is also an indicator of the better utilization among young people. And if mothers are educated, especially above, the secondary school level, those mothers and their children, especially their children, are a better utilizer of sexual reproductive health, which can be subjected to the awareness among mothers and the discussion with the children. And school clubs have the high, or positive association with the sexual reproductive health services utilization among youth. So our study concludes that we need to facilitate the awareness and understanding among policymakers and healthcare providers, because the low utilization is also, on the other hand, increasing the sexual reproductive health problems of the young people and putting them on more risk. We can provide, these findings can guide towards providing guidelines and direction for the future research, which I'm going to talk about in a bit as an example. And we should also, now align the practitioners' choices and practices, that what are their hurdles and what are the needs and demands of young people, so that they can be, mobilized, and they can be made to use the sexual reproductive health services that are available around them. Besides, this evidence have also, I would say, that open the doors to develop the stronger policies, approach the policy maker, or maybe we can work on the modifiable predictors to help the youth live, a healthier life and prevent the issues that is affecting their quality of life and quantity of life both. In terms of when we were working there, that what would be the applicability of this project in Canadian context. So even in Canada, we discussed and we saw that the people who are migrating from outside are not very much receptive of sexual reproductive health education. So probably these findings can help us, finding and targeting the interventions toward the conservative families, and work on the issues like how to improve the communication between children and their parents, and how can we take the parents in the confidence in developing the intervention that can target the immigrants of the Canada and help them, understand and accept the sexual reproductive health services education that is part of the school curriculums also. So probably pinpointing the specific needs of the parents and discussing with them, with their adults, will help the children to adopt the sexual reproductive health education faster as compared to just targeting the children alone. So what this meta-analysis brought into my life? So the gaps that I have identified through the meta-analysis, we have utilized these gaps, and we wanted to fix, we wanted to bring more puzzles to address the adolescent sexual reproductive health. So we wrote, a seed grant and applied in Aga Khan University, and that we secured by in June 2024, and right now the data collection is in process for that. Um, and besides that, we have also started a study about societal perception and healthcare perception, especially about the LGBTQ plus youth, because if we are talking about female and male, then we have, especially in Pakistan, a community that is not, that is still struggling with their place in the society. So if they are left behind, we still have the burden of the diseases as much as it was there already. Without addressing LGBTQ plus community, we won't be able to, perform any targeted interventions, because a huge part of our youth will be left behind. We also did a scoping review, and we wanted to see the outcomes of teenage pregnancies in Pakistan. We got the limited data, but it gave us the picture of that how early marriages are still there and how their preventable morbidities and mortalities are existing in the women's life, and also impacting the children and neonates. We also tried to explore that what is the utilization of SRHR among disabled youth, and we could not target the LMICs because of the limited data, but the global perspective has given us a very good, I would say, a mixture of the issues that we did not even expect that it can happen among the youth. So the needs, the demands, the issues are there for the disabled youth also, but they are even precipitated than the girls and boys we have just talked about. Future collaboration, I am more interested in seeing the genetic predisposition of prepubertal issues and mental health in terms of the biomarker evaluation, because in Pakistan currently we are seeing the young adolescent with the and late adolescent with the mental health issues. So I am more interested in getting to know that why it is happening and what are the key preventive measures that we can catch up before before its onset. Policy level interventions. I don't know how will I do that and when will I do that, because I'm still working and I'm still connecting the puzzles to reach the stage where I'll be addressing the policy makers that how can we address the gender disparity, including the LGBTQ plus community, girls and boys, and then make the cost, effective interventions to preserve the adolescents and youth health. So this is how it has shaped my entire research, I would say, approach. And I have reached somewhere where I'm thinking about the future grants and collaborations, and I believe that I'm done with the projects of 2024, 4 things which were there in my, you know, target list. Now I'm more focusing on future grants and collaboration and policy level things. And I would say that this project has not only boosted my career as an individual, but it has also given me a new thoughts, and it has improved me, my perspective to contribute into the society as a person also. So that's why this project is very close to my heart. So this is it from my side. These are the references which I have used. And thank you so much. Happy to answer if there is any question.